Pancreatic operation for tumor in the body or tail region of pancreas. Distal pancreatectomy. Less commonly, the whole pancreas requires removal called total pancreatectomy. The pancreatic head tumor surgery is discussed in a previous video. Hello. This evidence-based content is prepared by Saboor fellowship-trained consultant surgeon, and if you or someone you care about has been diagnosed with a tumor in the body or tail of the pancreas, you're in the right place. I know hearing the words pancreatic cancer and surgery together can be overwhelming, but understanding your surgical options is crucial for making informed decisions. Today we're going to break down the two main surgical approaches for these tumors, distal pancreatectomy and total pancreatectomy, and explain what each means for your long-term health. Your pancreas is a long organ that sits behind your stomach, divided into three regions: the head on the right side, the body in the middle, and the tail on the left extending toward your spleen. When tumors develop in the body or tail portions, roughly the left two-thirds of your pancreas, they present unique challenges. Unlike tumors in the head of the pancreas that often cause jaundice early on, body and tail tumors typically don't block the bile duct. This means they're often diagnosed later, when they've grown larger or spread further. The standard surgical treatment for cancers in the body or tail of the pancreas is called a distal subtotal pancreatectomy, and it's usually combined with removal of your spleen. Your surgeon removes the left portion of your pancreas along with the spleen, leaving the head of the pancreas intact to continue producing digestive enzymes and some insulin. Many of these procedures can now be performed laparoscopically or robotically, which means smaller incisions rather than one large one. According to data from the National Surgery Quality Improvement Program, the 30-day mortality rate for distal pancreatectomy performed between 2014 and 2016 was just 1.3%. In a high-volume center study of 2,135 patients, 28% developed one or more severe complications. The most common was pancreatic fistula, that's leakage of pancreatic juice from where the pancreas was cut, affecting 23% of patients. Other complications included postoperative bleeding in 2.7%, delayed stomach emptying in 6.3%, and chyli leak lymphatic fluid leakage in 6.3%. In contemporary series from high-volume centers, median survival for pancreatic ductal carcinoma treated with laparoscopic distal pancreatectomy ranged between 18 to 32 months. 3-year overall survival ranged from 22 to 42%, and 5-year overall survival ranged from 20 to 38%. These numbers represent patients who underwent resection, which unfortunately is only possible in a minority of cases because body and tail tumors are often discovered late. The majority have locally advanced or metastatic disease at presentation. If you're supporting someone through this surgery, understand that recovery typically takes several weeks. The median hospital stay is about 7 days, but your loved one may experience fatigue and digestive changes for months afterward. Total pancreatectomy means removing the entire pancreas, and it's sometimes required to achieve a microscopically negative resection margin. That's surgeon speak for getting all the cancer out with clear edges. This typically happens when a tumor extends from the head into the body or tail of the pancreas, making it impossible to remove all the cancer with a partial operation. Total pancreatectomy was first advocated to remove more tissue potentially involved with malignancy and to avoid creating a pancreatico-jejunal anastomosis. That's the connection between the remaining pancreas and intestine. That's a major source of complications in partial operations. According to data from the American College of Surgeons database covering 2005 to 2009, the mortality rate was 5.4% among 166 patients who underwent total pancreatectomy. That compares to 2.9% for pancreatico-duodenectomy Whipple procedure and 1.7% for distal pancreatectomy. Over time, the 30-day mortality rate has progressively declined, but the morbidity rate remains as high as 70%. In a meta-analysis of 45 comparative studies, total pancreatectomy patients experienced more complications than those having partial operations. Long-term oncologic outcomes are not necessarily better following total pancreatectomy compared with partial pancreatectomy. In that same meta-analysis, there were no differences in long-term survival rates between the two groups. Contemporary data on total pancreatectomy are limited by small numbers, but the data that exists support its use only where oncologically appropriate, meaning under conditions where it would yield a tumor-free resection margin, while a conventional partial operation would not. The metabolic consequences of total pancreatectomy, which include permanent exocrine insufficiency and brittle diabetes, have a detrimental impact on quality of life and long-term survival. If you're worried about someone you love facing total pancreatectomy, understand that these aren't minor inconveniences. They're permanent life changes that require daily management. Your pancreas produces insulin to control blood sugar. When it's completely removed, you develop diabetes that's extremely difficult to manage. Unlike typical type 1 diabetes, where some pancreatic function may remain total, pancreatectomy creates what's called brittle or unstable diabetes. Your blood sugar can swing dramatically from dangerously high to dangerously low, sometimes within hours. You'll require multiple daily insulin injections or an insulin pump. constant blood sugar monitoring, and meticulous attention to diet and activity. Without your pancreas producing digestive enzymes, you'll develop exocrine insufficiency affecting 64 to 100% of patients. This means you cannot properly digest fats and proteins. The typical characteristics of fatty stools associated with steatorrhea, loose, greasy, foul-smelling, voluminous stools that are difficult to flush, may occur, along with abdominal cramping, flatulence, and urgency to defecate. The main clinical manifestation is malnutrition and weight loss. You'll require pancreatic enzyme replacement therapy with every meal and snack for the rest of your life. This is essential for preventing malnutrition. These enzyme supplements must be taken consistently. Even when imaging suggests a tumor is resectable, laparoscopic exploration is often performed before attempting the actual resection. Why? Because a significant proportion of patients will have occult peritoneal metastases cancer spread that's too small to see on scans, but visible when a surgeon looks directly. Because ductal adenocarcinomas involving the body or tail usually don't cause bile duct obstruction, early diagnosis is rare. The majority of patients have locally advanced or metastatic disease at presentation. This is why in rare patients who appear to have potentially resectable disease by CT scan, laparoscopic exploration should precede attempted resection. The relationship between surgeon and hospital volume matters enormously. A meta-analysis of 14 studies found a significant association between high hospital volume and lower postoperative mortality odds ratio 0.32, as well as better overall survival hazard ratio for death 0.79. What this means in practical terms: if you're facing pancreatic surgery, seek out a high-volume hepatobiliary center where surgeons perform these procedures regularly. Ask about surgical expertise and volume. How many of these procedures does your center perform annually? What are your complication rates? High-volume centers have significantly better outcomes. Don't be afraid to seek a second opinion at a specialized pancreatic cancer center. Clarify the exact surgical plan. Will this be a distal pancreatectomy or total pancreatectomy? What's driving that decision? Understanding whether you'll keep part of your pancreas versus losing it entirely is crucial for preparing for life after surgery. Request a preoperative assessment. Ask for staging laparoscopy if it hasn't been discussed. Understand neoadjuvant therapy options. Some patients may benefit from chemotherapy before surgery to shrink the tumor, or identify those who progress rapidly and wouldn't benefit from resection. Expect a hospital stay of about 7 days, though complications can extend this. The postoperative complication rate is approximately 35% for resections of screen-detected neoplasms comparable to standard indications. Plan for enzyme replacement therapy. If you're having total pancreatectomy or even distal pancreatectomy, you'll likely need pancreatic enzyme supplements with every meal. These come as capsules. Brands like Creon are commonly prescribed. You'll need adequate doses of lipase, the fat-digesting enzyme delivered with meals and snacks. Work with a dietitian who specializes in pancreatic insufficiency. Prepare for diabetes management if total pancreatectomy is planned. This isn't optional. You'll need endocrinology consultation before surgery, education on insulin administration, blood glucose monitoring equipment, and a detailed plan for managing hypoglycemia, low blood sugar. Consider meeting with a certified diabetes educator before surgery. Arrange nutritional support. Malabsorption and weight loss are common. You may need small, frequent meals rather than 3 large ones. A high-calorie, high-protein diet with enzyme supplementation can help maintain weight. Fever above 101 degrees Fahrenheit, 38.3 degrees Celsius, especially if accompanied by abdominal pain, could indicate infection or pancreatic fistula. Signs of severe hypoglycemia if you've had total pancreatectomy: confusion, severe shaking, loss of consciousness, inability to wake. This is a medical emergency. Severe abdominal pain or distension, temperature, fainting or lightheadedness, difficulty breathing or breathlessness indicate complications. Persistent vomiting or inability to keep down liquids suggesting delayed gastric emptying or obstruction. Jaundice, yellowing of skin or eyes if you still have part of your pancreas, as this could indicate bile duct complications. Survival expectations. With distal pancreatectomy for resectable disease, median survival ranges from 18 to 32 months, with 5-year survival between 20 to 38%. These numbers improve with newer chemotherapy regimens. Total pancreatectomy doesn't necessarily offer better survival than partial operations, when both would achieve clear margins. Quality of life after total pancreatectomy. Studies show that the metabolic consequences significantly impact daily living. You'll need lifelong enzyme therapy, intensive diabetes management, and regular monitoring by multiple specialists: endocrinology, gastroenterology, and surgical oncology. Surveillance after surgery. Follow-up typically includes CT imaging, variable interval, and dependent on local practice. Symptoms, nutrition, and well-being checks are carried out. Tumor markers like CA19-9 are checked, especially if they were elevated before surgery. There is coordinated care amongst several specialists. Support systems. Connect with pancreatic cancer support groups. Organizations like the Pancreatic Cancer Action Network offer resources specifically for surgical patients and those managing post-pancreatectomy diabetes. If you're supporting someone through this journey, understand that the first few months are the hardest. Blood sugar management takes time to optimize, enzyme doses may need adjustment, and emotional support is crucial. Depression and anxiety are common. One study found that mood and anxiety disorders can be early manifestations of pancreatic cancer and persist through treatment. Surgery for body and tail pancreatic tumors requires expertise at high-volume centers, with distal pancreatectomy being standard, but total pancreatectomy sometimes necessary for complete cancer removal despite permanent metabolic consequences. Your next step: schedule a consultation at a specialized pancreatic cancer center to discuss your specific situation and surgical options. This information is for education. Always discuss your individual situation with your healthcare provider. I have outlined several reputable resources here, which you may find valuable for further information on this topic. All links are available in the description below. Thank you for watching.